We want to talk about the importance of the empowerment of the patient in the prevention of fractures due to fragility. Let's welcome Dr. Pilar Sáenz, coordinator of the National Registry of Hip Fractures. She's also a geriatric doctor. Welcome. Thank you for being here. I believe you have a presentation. I will also call Raquel Sánchez, a patient, treasurer of ICOSAR. There she is. Let's welcome Carmen, one of the pioneers in the world of associationism, and Raquel Sánchez. I already introduced her. You just heard her. You were also with us at the radio. She's a patient. Welcome. So, Dr. Sáenz, the floor is yours. Let's kickstart on osteoporosis. Thank you. Good morning to you all. First of all, I would like to thank you for inviting me to take part in this Congress, a first Congress for me for patients. I've never been in one for patients before, and I hope it's the first of many, because the time I spent here is the time I loved to see the perspective given. I was charged to talk about osteoporosis, the importance of empowerment of the patient, what you can do as patients to improve this problem. But before we start, allow me to focus on the definition. Osteoporosis is a problem of balance between bone resorption and formation. If there's more resorption, bone is lost, it weakens, and there is more problem or more possibility of a fracture occurring, which is the true problem of osteoporosis. Throughout one's life, from the moment one is a child until the age of 25 or 30, the bone is formed. It is then when we need to act the most. We need to have a good lifestyle, ingest calcium, vitamin D, exercise to obtain a good peak of bone mass to prevent this problem of osteoporosis occurring later. And this bone mass that has been acquired is maintained until the age of 50, more or less. And after that, we see a problem with the bone loss, more related with the loss of hormones. This is important when talking about prevention. Very important, primary prevention in youth, although this does not mean that we need to maintain it throughout our lives. Now, let us start with some figures. Close to 3 million people with osteoporosis in Spain. This is the fourth chronic disease with the greatest impact. It is a disease that affects women by and large. Almost 80% of patients are women. And it will increase from now until 2034, up to 30% increase. We will see more fractures due to fragility. The problem of osteoporosis are fractures. 3 million people suffer from osteoporosis, and every year 285,000 fractures. These are data from 2019, and every year the numbers grow. This is something similar to what you mentioned about obesity, a non-recognized and unrecognized disease. It exists. There's an important social, economic, and healthcare incidence, but it is not recognized and it is not given the importance it deserves. There's lack of awareness. Let's talk about expenditure. That's also important. This problem costs us more than $4 billion a year, 4 billion euros a year. It's funny to see, as you can see on the area with the wheelchair, that more than half of this expense is because of disability. That is, those with osteoporosis who have fractures present a disability, a functional deterioration that is very important, and sometimes it remains there for the rest of their lives. And there is a need to receive care in homes or at home, or maybe the children stop working to care for them, and this generates a further cost. Hospital costs or healthcare costs amount to 1.8 billion. It's not as much as that concerning disability, and the pharmacological treatment in the end is the cheapest component. It doesn't amount to such a cost. So this is what happens. We have a lack of diagnosis because we are not recognized. We have a fracture, but no one assesses why that fracture occurred, what is the underlying disease, and in the absence of a diagnosis, there is an absence of treatment. Up to 64% of people that suffered a fracture do not receive a treatment to prevent the next one from happening, and this is the biggest problem that we face with osteoporosis. Why is it a problem? Because if one suffers a fracture, they will have a 3-fold chance of having a second fracture if nothing is done. And after that second, a 5-fold chance. After the third one, 8-fold chance. The sooner we act, the sooner we will be able to avoid this big snowball. And that is why, right now, we, the experts, are insisting on treating, especially after the first fracture, because these are the patients that are at greater risk, the patients that will benefit from the treatment the most. A few years ago, a lot was said about treatment on postmenopausal women. And the truth is, I'm not saying they are not at risk, but they don't tend to fall so much, and the fracture is less prevalent. So we need to focus much more on non-pharmacological measures at that age, and when there's been one fracture, we need to focus on a more comprehensive treatment. Let us move on to proposals for improvement. In these proposals for improvement, we all need to work on many things. This is a Congress for patients, and patients have a lot to say. What should we do? First, to know the disease well. Doctors and patients should know it well, to put the means to prevent it. Then to know and find out more about the resources available to prevent it, and then cooperate together to achieve it. Let's get to know the disease. I think most already know what the risk factors are that predispose one to suffer fractures because of fragility. The most important ones with high risk are to be over the age of 65, to have a low weight, to have a background, a previous record of a fracture of that of our mother, to take corticoid treatment, or suffer risk of falls. All of these factors produce a high risk of fracture due to fragility. And there are others that are more minor, such as drinking, smoking, early menopausia, factors related to falls, such as visual deficit or impairment, things like that. They cause a moderate risk, but they also increase the risk of fractures. As a result, what should we do? We should modify our lifestyle with a balanced diet, provides enough calcium and vitamin D, suitable exposure to the sun. Unless we don't want to take vitamin D, we should expose ourselves to the sun, adequate physical exercise, avoid toxics, and prevent falls. When it comes to prevention of falls, this is a new development in terms of our society, because it's very often for these fractures to occur following a fall. And this fracture is attributed to the fall and not osteoporosis. Fractures are because of both things, osteoporosis and falls. We need to treat osteoporosis and prevent falls. We need to remove obstacles in the home or at street, the typical tile that we trip on. We need to assess if there's visual impairment or vertigo or maybe unsuitable footwear in an elderly person. And we need to review the drugs. That we have too many. We need to review them. It is true that we are increasingly giving importance to this problem of falls, and from the Ministry of Health in 2014, they prepared a document on consensus to prevent falls and fragility, and they renewed that document in May 2022. So they say to us, the doctors, that once a year, people that are independent, the Bartle greater of 90, people that are independent must be interviewed at least once a year to ask them about any falls or to see if they have fragility. A series of tests are made, and those who fall frequently or are fragile should be offered a more intensive treatment in nutrition, physical exercise, and healthy lifestyles. And this is what we will comment on. Nutrition must be balanced, but we need to talk about osteoporosis, so an intake of calcium should be suitable. We know that the dairy products have calcium, but if one does not tolerate them, dry fruits, vegetables, fish, seafood, there's a lot of calcium there too. And vitamin D, we can do it by means of exposure to the sun, eggs, liver, or fatty fish. If we can't tolerate these drugs, there are always supplements or tablets that we can take with vitamin D. And of course, we should remove toxics from our diets, alcohol, tobacco, caffeine, and salt. These are not good for patients with osteoporosis. Physical exercise is key. We need to be healthy, and we should prevent falls. Physical exercise prevents us from falling, strengthening the bones. It must be individualized, and it must be daily. This means that it increases our muscle strength, increasing mineral bone density, reducing the risk of falls. This should be aerobic exercise, such as walking or riding a bike, but there should also be some strength exercise. That is to say, using some weights, elastic bands, or maybe do press-ups or ups and downs, getting up and down. It's also important to control one's balance. For the patients with instability, they can work on the balance to prevent them from falling. Exercise is key. There are drugs for osteoporosis, and they're great. It has been demonstrated that they've got proof of reducing fractures. And there are clinical practice guides, such as this one that I'm presented from the IOF, that depending on risk and the age of the patient, if the risk is moderate, one type of drug will be used. If the risk is high and it is orally intolerant, denosumab can be used. Or if not, if there's good tolerance and if youngster, biphosphonates. And for those with a very high risk, osteoformers are used. The drugs for osteoporosis are efficient. That's true. It's a chronic disease and we need to maintain them for a long time, but they are very useful and we need to take them into consideration. Let's move on to the next step. We said that the patient must know and be aware of the disease. They must be aware of the factor of risk to prevent them. The next step would be to know about the resources, because patients must know what resources are available to the doctors or what healthcare models are available to improve care, to improve the healthcare services we provide. So let me comment on the 4 proposals. The fracture coordination units, to be able to issue a fracture code in the same way that there is a stroke code, the ortho-geriatric units, and the fracture registries. The coordination units are a multidisciplinary task force where they try to detect the patients that have already suffered a fracture. They are assessed to see why the fracture happened, to see why they suffer from osteoporosis. They are treated pharmacologically and non-pharmacologically, as we have mentioned. Then there always needs to be a coordinator who should be the person detecting the patients with fractures, and they would refer them to the clinic to assess them and provide the necessary treatment. There needs to be perfect coordination between the hospital and primary care to ensure this works seamlessly. What are the results achieved by this coordination unit? Well, there is better diagnosis of the problem, there is better treatment, we increase the treatment up to 20%, even adherence, and we have seen a reduction of 5% in refractures. So following the first fracture, we were able to reduce new fractures from happening in 5%, and we've also reduced mortality by 3%. There's an international organization, the IOF, which recognizes the fracture coordination units according to how well or how bad they work. So they give them bronze, silver, or gold medals depending on how they work. There are 735 units, in Spain 76. This means that only 18% of Spanish hospitals have one of these coordination units. And this is one of the things that you as patients can help us to implement, because we have demonstrated that they are useful, and it would be good for you to know, to ask for it as well, to demand it. The next proposal would be the fracture code. You know that there's the infraction and stroke code, and one is in a hurry, one suffers a stroke, right, to follow the necessary treatment. So with fractures, we should have a fracture code too. This is a possibility. We can ask for it. We are in a hurry to treat patients who have suffered one first fracture to prevent the second one from happening. If we had to use a fracture code, the most interesting one would be the hip fracture, because in the hip fracture, we are hurried to operate. Patients who wait too long to undergo surgery have complications, and sometimes they can even die. This is data from an international OECD report where you can see that most European countries operate hip fractures following the first 2 days. We only do it in 50% of the patients. We are lagging behind Europe, and we are trying to work to operate them as soon as possible, but it is true that we're finding problems. The hip fracture code would be very useful to help. How do we treat elderly patients when they are admitted into hospital? The best way of treating them would be the third proposal, the ortho-geriatric cooperation unit. So a multidisciplinary task force made by traumatologists, geriatrics, interns, and anesthetic experts to treat treatments with an average age of 65 years old, which is the average age of these types of patients that see complications the moment they come through the hospital. They see pneumonia, pressure problems, unbalance in the heart, and they need, in addition to a traumatologist, a clinical expert working together with them. These units have demonstrated that they are treated in less time with an average stay that is shorter. They die less. They walk better once discharged, and cost efficiently it's much better. This unit is a cheap one after all. What you invest is something that ends up being cheaper. What I am telling you is something we describe in a dissemination document on social media, where we demonstrate the benefit for the patients, for the managers, and also for the multidisciplinary task force with the support of all scientific associations that you can see on the screen. And lastly, the last proposal will be to use the registries. Clinical practice guidelines tell us, the doctors, how we should work, what we need to do, how we need to care for our patients, but nobody measures if we are actually applying them or not. That is why we should use the registries. The registries are an audit, and what they do is measure. By gathering information, we detect deficit, we implement improvements to correct these deficits, and we use the same registry to see if these improvements have been useful or not. They can be used as an audit to compare one hospital with another. In all European countries, there is a national registry for hip fractures. In Spain, we didn't have it. So, in 2017, a group of professionals, traumatologists, intern experts, anesthetic experts, rehabilitators that usually treat patients with a hip fracture, came together to consider creating a national registry for hip fractures. We started gathering data in 2017, and we already have 105 hospitals included in the registry. What does this registry provide? It provides us with information, and now we already know that the average age of patients with hip fracture in the Spanish hospitals involved is 87, as you can see on the left. Most operate. 97% of them do, despite having being 87. They spend 10 days on average in the hospital. We need 66 hours to operate. As I said, we need to try to reduce this time. More than half don't walk after 30 days after the fracture. So we see that there are many areas for improvement. If we do not have a registry, we do not know how we do things, and we cannot improve because we do not have this information. Now we do have it. So in this snapshot that you can see here on the left is found in every hospital every 3 months. Every 3 months we send the analyzed data, and the hospitals already know where the deficits are to be able to improve. We have the endorsement of all scientific associations you can see on the right, and we draft an annual report with all of the activities we carry out throughout the year, and the results are presented in an anonymous way. This is the surgical delay of the various hospitals that are involved. Some hospitals take 15 hours only, whereas others 120 hours. There's a big variability in all of the results amongst hospitals. So what have we gained in these 5 years, since 2017 to 2021, working with this registry? More than 100 hospitals participating. This is the graph of the benefits of this registry. We have reduced down to 20 hours the delay in surgery, which is the time they take to be operated. We mobilize the patient sooner. Only half in the past was raised the day after, and now 60% of them are. We have increased treatment of osteoporosis. In the past, only 36% of the patients were treated, and now it's 50% of them. And we have reduced ulcers because of pressure in a good percentage. They can still cannot work better after 30 days. This is an area for improvement. So what tools do we have, doctors and patients, to improve the care for patients with fractures? The fracture code, coordination units, a better coordination between primary care and hospitals, the orthogeriatric units, which we do not know how many there are in Spain, and we would love to know and see them in all hospitals, and use the fracture registry. For now, it's voluntary. It's a voluntary effort of the many professionals, and we would love for it to be an initiative of the ministry, like we can see in all other countries in Europe. In other countries, there would be a registry of fractures with their own staff, and it should not be a voluntary work. And lastly, cooperate clinicians, scientific communities, and patients to achieve all of this. 2 days ago, we were at the ministry talking at the Congress with 2 MPs, and this is what we need to do. We need to convey patients and scientific associations, doctors, to the politicians that these tools are useful and that they should be implemented. Not only in 18% of the hospitals, all hospitals should have them. As a result, the raising of awareness campaigns should demonstrate that patients know that this is a disease, that there is a treatment, that there are tools, and they are useful. We need to disseminate this. In a congress like this, I'm thrilled because I really love to see that there's so many interested for this issue, so you can inform all of your friends and relatives. And the slogan of the latest campaign was, break your statistics, not your bones. So let us not see an increase of 30% in fractures. Let's focus on the statistics. Let's reduce these numbers. I was also asked to tell you about an example of the hospital where I work, where they are counting on the patients in the clinical commissions of the hospital. So patients will become involved in the decision-making process of the hospital itself. I work at the University Hospital Fundación Alcorcón, a hospital in Madrid, and in March 2022, an idea emerged. Probably Carmen knows about this much better, but I think it's a result of a management commission that patients have a lot to say in the decisions of the hospital. An informative meeting was held at the auditorium of the hospital on April the 5th, and they called all associations with headquarters in Alcorcón to attend. After informing them, they held interviews in May to all associations to know what each association did, and on the 20th of June, the Commission of Patient Associations was set up. It is formed by someone from primary care, someone from specialized care, the director for care content, social worker, and 7 associations of patients that have their headquarters at El Corcón. Others cooperate in other work forums that are not part of the commission. What are the goals of this commission? To give visibility to associations, to know what they're working on, and to be able to work together. Associations should know what we do at the hospital too. Patients should make proposals for improvement. We all know that we get to the hospital and we think, how come they called me one day for anesthesia, another day for analysis, another day for x-rays? Why don't they call me for the same day to do it all? I'm sure you have many proposals that doctors don't even think about. And you can make these proposals in this commission to improve. Review processes, review documents. Informed consent, for example. Sometimes that document is something people don't understand. We write it just for ourselves, not for you. If you review these informed consent forms, you can say, if you write it this way, maybe we can understand it better and we could change it. More accessibility physically and digitally, and also to know about all the social and healthcare resources in the population, in the town, to offer them to all patients. These are the associations that are part of the commission. The relatives of Association Relative of Alzheimer's disease, multiple sclerosis, and many others. And 3 more participate in other processes, ICOSAR, alcoholism, and fibromyalgia. Lastly, I was asked to say how a fracture coordination unit is structured. I might not be the person to describe this because we still don't have it.
Para crear una unidad de coordinación de fracturas, primero tienes que identificar en el hospital qué profesionales están interesados en colaborar, en hacerla. Después hay que consensuar el modo de atención, juntarles en una reunión y decir cómo lo vamos a hacer, cómo vamos a trabajar para prevenir las fracturas. Después, proponer las medidas que vamos a hacer y estimar los recursos. Necesitamos una persona más, una enfermera, un médico más, estimarlo y presentarlo a dirección, a ver si cuela, digamos, a ver si se consigue ese recurso. Y adaptar la nueva actividad, la nueva unidad de coordinación de fracturas a los recursos que nos den. Si nos dan algo mejor y si no, pues intentar avanzar, aunque sea sin recursos. En nuestro hospital, ¿por dónde nos llegamos? Ya hemos identificado los profesionales interesados y ya hemos consensuado el modo de atención, que es crear...
We have agreed on creating a protocol based on the clinic so that we can all treat patients the same, whether it's in the hands of a traumatologist or rheumatologist or geriatrics or the GP, to know about the tests to be made and the treatment based on the patient. That's what we got, but we're lacking still the resources, but we'll fight for that. I think that this was interesting to know because these type of units have not managed yet, but I've told you about how it is important to have physical exercise to prevent any falls and fractures. And precisely when discussing this with the city council and telling them about falls in the case of the elderly patients, since this was organized by the city council, after that discussion we talked on the meeting to have a scheme for preventing falls at a sports municipal center, and this is something that we were not after, but that we managed to achieve. And this is how you often get it. You need to find people that is aware of this, and on November the 3rd we will be starting this program for the prevention of falls, regardless of their age, whether they're 80, 90, but that's a group of 12 patients where some sports coach will try and help them in preventing their falls. So we try to do our best in order to prevent falls and fractures. as a conclusion. And I think that we've gone through this to improve on secondary prevention, improving on registers, using the clinical guidelines, schemes to prevent falls and fractures, to use these fracture units in hospitals, also raising awareness, and that's important, so that doctors and managers know about what's required, and then promoting research. We need to work together, the doctors, patients, and with a full political commitment. What we submitted a couple of days ago to the members of the parliament was part of an association with the support of all the scientific organizations, which has been a good way to disseminate this problem. Thank you. I really liked her saying this is the first time she's addresses the patients, but the feeling is quite different. I got to meet Carmen some years ago in a meeting in Madrid at an event where we were touring around Spain with patients' associations. That was on the World's Day of Osteoporosis. It was October the 20th, and I would like to ask the president of ECOSAR, the Association of Osteoporotic Patients, Dr. Burgess, to come to the stage, because last Thursday, on October the 20th, and I'll hand over to him microphone 2, by the way, and maybe now he can tell us in a nutshell what this was about. Congratulations, by the way, on your presentation. You did really well. You can see that we patients are loving you being here. Well, October the 20th was a great day. We did so based on our association, on our platform of patients. There were us, then AFOEMO, and ACOSAR. I think you, Carmen, were on Toledo on TV. You know, she's a TV person. You go to the parliament, to the Spanish parliament, and Carmen, as you were saying, has been for years as an expert patient with a knowledge on OP, on osteoporosis. And again, we with this motto of breaking statistics without breaking your bones, and let me tell you that in our associations we are strongly in favor of this, and we are scientific members of these platforms, and patients-wise we have Carmen and Raquel here with us, and several patients with OP, and we have a close cooperation and support, and count on us regarding the registry, because they know us and the health decision making and then I think that we need to lobby on that. We patients are totally in favor, and we will do our best on that, because this is a very important condition, OP, and you were reporting that the statistics on fractures, and I'm sure it will increase. So again, we, from the patient side, are for it, we will support that, and of course you are the doctors, but then you can count on us as patients. Just wanted to mention that. One thing I like to ask Raquel, for how long you were diagnosed OP? Well, no, that was a question for Raquel, sorry. I was diagnosed in 2020, 2019, yeah, just recently. Do you think that from then on you've been properly notified, you've come to know the proper treatments, the hygienic, nutritional treatments? Well, this is one of the things I will be expressing, that I got the information from ECOSAR, but not from my doctors. So the value is in the patients' associations. Yes, fully, totally. Because I think it's a shame that it's in the rules of the game that we do not have this feeling of abandonment, and not even during the pandemic, because We are not used to follow up. And that's really a shame, that's a pity. And all this time that we've been like abandoned, thanks to people like Dr. Vergés, well, it's the touch with the daily touch with patients, the one, unless we take care of ourselves, no one will. You, Carmen, were diagnosed with OP some 10 years ago and were amongst the first to claim for an association for patients to group together because, and that's where OAFI is, that's something that can make a difference, isn't it? Yes, and based on what they've been saying on disability in the previous presentation, well, let me tell you, OP is not recognized as a condition that disables the individual. And here today I'm calling for it to be approved as a condition which is disabling the individual. Osteoporosis, OP, not just OA but OP as well. It's a surprise that it hasn't been, isn't it? I mean, it's like obesity, isn't it? Like Federico was saying. Yes, but because there is an impact on our daily life. I mean, I can no longer be hugged like I was by my children. I mean, they may have even broken my ribs because of their effusivity, or the fact of me not playing tennis on a Sunday, or like not being able to go on skiing on a Sunday, or the fact of not being embraced by my very children. And all these feelings, all these frustrations, all these profound feelings is something that you get to know as a healthcare practitioner, or is there like a sort of a moat or a pit separating you? Yes, there is much separation. It is well known that after a stroke, and this is something that we were discussing recently at the Parliament, you are discharged with some pills, then some appointments with primary care, and then you will be weighed, you will be tested on your blood pressure to prevent any further strokes. And this is well known when patients with this type of pathologies may feel like they are properly followed up. But in the case of OP, that's close to null. Unless there is a unit coordinating fractures with a closer follow-up, unless there is no follow-up. I mean, it's not recognized as an issue, not by many patients and nor by many doctors. So unless there are some specific units, we don't have the ability to bring in the patients every 3 months unless we are part of a unit that has greater resources. Now, talking about that, how can we increase the fracture coordination units in our country? Well, I think it takes hard work. We need to submit data to managers, the ones that are the decision makers, and there is plenty of scientific evidence, plenty of papers. Dr. Naranjo, which is quite active on that, has proven the outcome, the result in Spain, in showing not only these abroad but also here in Spain. So in these fora and in these places where we have this opportunity, we should be asking for it, because I think that's crucial. So, a couple of questions maybe. I would like one thing, if I may, considering the importance of what the doctor just said, is back to the need for protocols. The fact of not even knowing who's the expert that will be in charge of our situation. I mean, I've faced different specialists, for instance, like the traumatologist that is now the one that's now more hands on me, but I've seen like tests read differently, or even different protocols, or I've been told that I'm like the ideal patient because I have not asked. No, it shouldn't be like that. I mean, to me, there's been a before and after I got in touch with them at ACOSAR. But I would like this not to be the rules of the game. But I would say that the next time it will be the rheumatologist, the true expert, isn't it? Yes, because I know that this is a cross-cutting condition. It's an endocrinological condition, and it should be these experts that should be in charge, and then rheumatologists, of course, they do as well, but then an endocrinologist should be the one. And the GP, primary care, should also take that into consideration. You may know about the survey we did, and we saw that in Spain, patients were really happy in a hospital setting where they said, for instance, they got an OP fracture and they went through a replacement. The problem is after being discharged, and then there is a mismatch between primary care and hospital care. And that's where they can get this second or third fracture after being discharged, knowing that primary care is overstressed, but then that's quite an issue. And for those of you interested, we have lists in our website with all the hospitals that, as the doctor here was pointing at, have a fracture coordination unit. So you can know which hospitals these are. Then, since I have Dr. Santigna here with me, and he has been the past president, and that there is much work done with these units. There is a proper coordination of this, and we are there. I mean, Ecosana is there as well. So we are there to help, to support, and we will. And a couple more things before we conclude. One of the coming discussions that will be delivered by José Luis Vaquero. This is one of the issues we are facing at OAFI and ACOSAR. And this is a program we submitted to the Spanish Parliament, to the Ministry of Health. And we can save much money if we properly collaborate with us patients. And one more thing that has been mentioned here, and that we'll have a presentation tomorrow. The OAFI Space, first program I know with both architects and doctors telling how the bathrooms should be, how the houses should be, because there are many fractures taking place in a toilet because you don't have a rail bar, or because you don't have a shower thing. I mean, bathtubs are the worst thing you can have in that regard. So you have us as patients, we are really driving for things to come true, so count on us. And as a matter of fact, Santiago Niño Becerra was saying that the role of patients will become more and more important because we are empowering people, we want to improve. A couple of questions from the audience. Yes, please. Good morning. This fashion, this trend we are now seeing on children not being given milk and instead something else, is that a good thing? Well, the good thing would be a balanced diet and not taking anything away from the diet. I mean, if you are lactose intolerant, of course you need to find an option, but it's not necessarily good. Well, I'm addict to milk myself, and I've always been told that I've accumulated so much milk that my bones are perfect, and I see children around not being given milk. And so this just shocks me. Yes, but you need to take into account the individual. So again, I've always been addicted to milk myself, and yet I have a serious OP. So I'm sure that there is a genetic background to it, don't know what, but anyway, I can attest to that, and this is something that I want my children to know. And one of the things that I've also learned in the association, and just like the doctor pointed out, whatever you do until you are 25, 30 will properly determine your future. And if you don't drink milk, then that's an added component. And if you add the genetics to that, maybe that's the end of you. Yes, because otherwise you need to obtain these from other sources, usually pharmaceutical sources. And having natural products such as yogurt, milk, or all these sources, well, you can provide for that naturally. Dr. Rand will precisely talk on this topic, on the diet in the case of OP. That will be explained much in detail, and you will see that later on. Now, who's holding the mic? Sorry, didn't see you. Yes, we've run out of time, but just a quick comment based on what you said. Congratulations, doctor. I think it was great to see this meeting of heads of professionals back in 2007, thinking about the need to raise awareness, which is something that is much required. And I agree with you in that many people don't even ask, as Raquel was saying. At OAFI, we get many calls talking about the injections that many doctors claim for OP, and they fear about their adverse events. Again, there is a gap here. One more thing. There are people that stay at home, that they don't exercise, and the pandemic has been brutal on that. And as a sort of an encouragement, Carmen, he's 20, as you can see, well, it was 7 a.m. yesterday, and he was right at the station waiting for the train to come here. So we need to never stay at home. We need to do some moderate exercise. Yes, Raquel was accompanying his father. And what time did you wake up? Yes, I woke up at 5:30. Yeah. Now that's quite some wee time, isn't it? Yeah. And on physical activity, going to Alcorcón, how many patients do we have there? Over 150 patients in Alcorcón. It's been quite a work. We started off with 5 people only. Well, the treatment of OP is, we don't have much, maybe a bit less than OA, but good news is that recently with the portfolio of services, a new drug has been approved. And that's a medication drug that patients with OP and with fractures will cover their needs. And you know that medication drugs do not suffice by themselves, but hopefully it might be useful to some patients. We will see that soon. We'll see about the efficiency of this new medication for OP, because it took its time for its approval. It was approved by the Spanish agency, and then Carlos Lenz and all the people from the European Medication Agency that came here told us about this. But anyway, it's been approved. It's good expectation. We have a good arsenal. We have a good deal of tools, and there were some secondary effects, some side effects that would lead to people fearing that, and even some treatments that have been withdrawn. But again, as you get to know the condition, as you get to know the medication, you shouldn't be fearing that. You need to compare that to scientific terms, and this is why, again, the fracture special unit is a specialized team that knows how to approach these patients. And since you mentioned that, and I think that they are doing quite a good work in organizing the fracture special units with much quality. Knowing that from within, I know that it's a great work. Let me add only that when the doctor, when there is a treatment suggested by the doctor, first, that's a customized treatment, that's an individualized treatment. And secondly, Side effects. Everyone knows that a medication has its side effects, but if the doctor suggested that treatment to you, it's sure that you can take that medication and the side effect or the adverse effect will be minimal when compared to the benefit for you. That's the only thing I wanted to clarify, because later in the association we get calls like, well, I got this medication, what did you get? And I mean, it's very important to bear that in mind. So later on we have the stands visit. Thank you very much. It's been a pleasure.